Good morning. It's a real honor and pleasure for us to present the NAS TSG Award for the third consecutive time. Now, the topic of presentation today is Modic changes and its association with inflammatory and host defense proteins. Now, we all know that from the time these changes were described by Roos and classified by Modic, they have occupied a center stage in the discussion and scientific literature. Now, the Isels Prize winner a few years ago actually showed that Modic change is an independent risk factor for severe and disabling low back pain. So patients with Modic change have more pain more often, and also a different kind of pain. And in the European Spine Journal publication a few months in 2020, we were able to show that the postoperative surgical site infection and outcomes were quite different and high in patients with Modic change. Now, there is a universal discussion and a lot of literature which proposes that Modic change may in fact represent low-grade subclinical infection. Now, the aim of the study was to cement that proposal, to investigate the basis of unsatisfactory outcomes in Modic changes, to identify potential targets for molecular therapy, and to analyze the possible role of infection. Now, this was a prospective cohort study and experimental analysis done at Ganga Hospital between April 2018 and December 2019. Consecutive patients were enrolled for the study. So there were 309 patients, of whom 86 had Modic changes and 223 did not. And they were analyzed on 3 counts: clinical and functional outcomes, proteomic analysis, and amino acid analysis. The proteomics workflow is standard, what is performed and utilized around the world, and this was the same that was adopted. For clinical and functional outcomes, we utilize the VAS score, the ODI score, patient's satisfaction by McNabb's criteria, and postoperative infection. And in proteomic analysis, we not only looked at protein expression, but also looked at biological pathway analysis and looked at host defense response proteins. Now, you'll find here that on your left, on the relief of leg pain, there was no statistical significance between Modic change and non-Modic change, but the ODI score was significantly higher in patients with Modic change and non-Modic change at the end of 1 year. We also found that the McNabb satisfaction at 1 year was also significantly different, with poor results in Modic, and postoperative surgical site infection was 4.7 in Modic change and only 0.5 in the non-Modic group, all highly statistically different. Now, for proteomic analysis, we did the 585 proteins were identified and 536 in non-Modic. But when we applied a stringent filter of greater than 5 PSMs and sample positivity in 30%, it was narrowed to 208 proteins in Modic change and 193 proteins in non-Modic change. Now, the differentially expressed proteins were found that there were 163 differentially expressed proteins between these 2 groups, and this was looked at by having a logarithmic statistics. Now, in the Modic change, there were many upregulated proteins, and you could find that it was acute phase reactants, which are usually produced in trauma or infection as apolipoprotein or amyloid P component and ceruloplasmin, or it was the immune system responses to antigenic exposure, like dermicillin, which we know is a very important response in the biologically whenever there is an infection, and also many cytoprotective proteins in response to inflammation and infection were found, which were found to be either uniquely or upregulated in the MC group. Contrary, there were also many downregulated proteins in which collagens and proteoglycans, which form the substrate, important aspects of the matrix, were found to be down. Proteins essential to control infection like tenascin and regulators of infection like serpin, they were all found to be low, which shows that in the disc material of Modic, there was an active inflammation going on. We then looked at the comparative biological pathway analysis, and this actually showed that there were many infection-mediated immune-influenced pathways and immune-responsive pathways. And for example, the FCGR3A mediated phagocytosis in Modic disc was found to be highly expressed. Now, we know that these are usually present whenever there is a subclinical infection or any infective process, and that increases the role of a question of whether there is a bacterial role in Modic change. Now, for the controversy of whether these bacteria are contamination or they are actually an infection, we wanted to look at host defense response proteins. And we know that host defense response proteins are present in the tissue only when there is an established infection and not when there is a contamination. And you will find here that there were 14 host defense response proteins which were uniquely present in the Modic change, but only 2 which were present uniquely in the non-Modic change. All of which increase the possibility that there is an infective process going. As I told you, we already proved that there is a high infective rate and poor ODI in patients who underwent surgery. And we analyzed that by proteomics and amino acid analysis that this could be because of inflammation and infection. Now we know that in the onset of degeneration, there are mechanical factors, genetic background, individual and environmental risk factors. But we also now, this is increasingly being found that innate and adaptive immunity, low-grade inflammation, and low-grade subclinical infection are being a part of this whole process. Further analysis into the protein pathways and biological process showed that there was evidence of ubiquitin-mediated degradation. And we know that ubiquitin-mediated is a selective degradation of damaged proteins that are tagged by ubiquitination and are degraded in the proteasome. And this will always increase the presence of glutamine and glutamate accumulation, which was actually the case in our series with Modic change, where we found that there was a higher accumulation of glutamine and glutamate. So this allows us to propose some molecular targets to improve outcomes in Modic change. We know that ubiquitin-mediated proteasome degradation can be countered by bortezomib and molecules like carfilzomib, and anti-glutaminergic therapy with riluzole ketamine and lamotrigine are also possibilities. So in conclusion, this study has proved that chronic bacterial exposure can give rise to host defense response proteins, which is indicative of a subclinical infection. That leads to a lot of inflammation, ubiquitin-mediated proteasome degradation pathway, and glutamate production. All of these will be associated with poor outcomes. Once we know that these are the pathways, we also know that these can be countered at different areas. Now, antibiotics and probiotics will help at this stage and prevent an infection. TNF-alpha blockers can reduce inflammation. Monoclonal antibodies can counter ubiquitin-mediated proteasome degradation, and glutamate production can be countered with anti-glutaminergic therapy. And we hopefully think that a thought process and more experimentation on this line will lead to more understanding of this. Thank you very much again for this opportunity. It's a great pleasure to be connected. Thank you.